Hi, welcome to this lecture on conditions of the knee. These are particularly focused on conditions that you might come across in physiotherapy. They're not exhaustive or exclusive, but hopefully we'll cover the majority of conditions that you may come across, both as an outpatient physiotherapist, but also within inpatients. In this slide, you'll see that I've classified knee problems that you may come across as predominantly soft tissue problems or as particularly bone and joint problems. And so you see that under soft tissue problems, I've classified soft tissue problems as ligamentous injuries, meniscal injuries, tendinous injuries, or bursitis. But also within that, you get muscle damage as well. Bone and joint problems include patellofemoral pain syndrome, although in reality, patellofemoral pain syndrome is more likely to be a combination of both soft tissue and joint, but the pain occurs at the joint. Other patella problems include patella dislocation and fracture. Other fractures that you may see around the knee might include femoral or tibial fractures, which are part of the knee joint, knee osteoarthritis, osteochondritis dissecans, and then two problems, Osgood-Schlatter's and Sinding-Larsen-Johansson syndrome, which are problems that you specifically see in adolescents. These are known as apophysitis problems, and we'll talk about those a bit later on. If you think back to the session that we did on classification of disorders of the muscle, this is a slide that we used then and considers classification of soft tissue injuries. In a grade 1, you get no appreciable sort of damage of the muscle or ligament, so no tearing of the tissues, or maybe just tearing of one or two fibers. But you get a sort of low-grade inflammatory response, and there'll be no appreciable loss of function or strength particularly, although there might be a little bit of pain. In a grade 2, you've got more appreciable tissue damage, and because of the greater degree of damage, you get some functional problems occurring, some loss of strength, and maybe some functional sort of activities are lost. As a grade 3, previously, when you look at the grading of sort of O'Donoghue and Takabayashi in '95, these ones both classified at grade 3 as a complete tear of the musculotendinous unit, whereas Ryan suggested that that was a tear of many fibers, called that a grade 3. Ryan in 1969 called a complete tear a grade 4. So you'll see that there are some problems here because people graded things in the past differently but meaning similar things. So this led Muller-Wolfart in 2012 to reclassify particularly acute muscle disorders and injuries, where type 1 were classified as functional muscle disorders, where things like fatigue or delayed onset muscle soreness influenced perhaps the ability of the muscle to function, but there was no appreciable tissue damage. Within this functional muscle disorder, there were also neuromuscular problems, both spine and muscle related. These are type 2, causing problems with function, but not, again, tissue damage. Tissue damage was classified within types 3, partial muscle tears, and type 4s, sub or almost complete muscle tears going on. There were direct muscle injuries also that were classified as contusions, lacerations as well, but they were not classified in the same way. So it's just be aware that actually when you read about classification of muscle disorders or grading, you have to be aware about which kind of muscle grading is being used. But remember that we don't actually treat the grade of muscle tear, we treat the symptoms that actually occur as a result. And then we come on to fractures. For a more complete discussion of fractures and classification of fractures, I would refer you to Solomon and Apley's book on orthopedics and trauma. But it's useful to understand some of the names of different types of fractures. And here we've got some examples of sort of long bone fractures. Where you've got a fracture that is sort of straight through the middle of the shaft in a sort of crossway, that's a transverse fracture. Then you get linear fractures which follow the line of the bone, and they I think are not as common. Oblique ones, as you can see, are a sort of diagonal line, and where it's you get displaced or non-displaced. In things like road traffic accidents, or where there's been sort of a clear direct blow to the bone, displacing can occur. Spiral fractures occur when the bone has been twisted in some way. So if you think about if you take a rolled up towel and were to twist it, you see what a spiral fracture might actually look like. Green stick fractures are not complete fractures at all, and these are more common in young children where the bones are still not kind of fully formed. And then at the final, more complex stage, you get comminuted fractures where not only have you got a fracture, but there's several, the bone's fractured into several smaller parts, and these are definitely the more complex types of fractures. It's also worth considering also the stages of healing of fractures. So in the early phases of a fracture, you'll get hematoma forming around the fracture site, so you get bleeding. That bleeding then, the next stage of that causes inflammation. So the stages of inflammation occur and you get swelling, redness, and edema. And then as the bone starts to heal, you get a formation of a callus. So the bone starts reforming around it, but you'll see that the sort of callus forms not just exactly at the ends of the bone, but it might be sort of larger around the fracture site. And that then becomes consolidated, it becomes more firm and stronger, and it's only at this stage I'm really considering that the bone to be actually beginning to be healed properly. And then you get remodeling, where excess bone around the fracture site is reabsorbed, so that you don't get the sort of bone in a sort of very misshapen way. Fracture healing times are quite approximate and quite variable, but Perkins' classification of fracture healing suggested that this sort of initial union of an upper limb fracture, so that's where the bone is starting to sort of heal, but it's not as strong as it, it's not fully strong again. So in a spiral fracture, it would occur in about 3 weeks because the ends of the bones tend to be much more aligned. Although you might think a spiral fracture is more complicated, it actually heals better. And you'll get union of a transverse fracture in 6 weeks. But consolidation of upper limb fractures can take between 6 and 12 weeks, where these numbers are roughly doubled in a lower limb fracture. So in a transverse fracture of a lower limb bone, say the femur, it can actually take up to 24 weeks for a bone to become completely consolidated. If indeed fracture is disrupted, healing is disrupted in some way, you can get malunion where the fracture unites within that duration of time, but the fragments are not aligned in a acceptable position. And in some cases, orthopedic surgeons may well then go in and refracture, re-break the bone in order to set it in an appropriate way. In some cases, you can get non-union, so whereby even though the normal healing time has passed and in fact suggested up to twice the normal duration, you're still not getting union of the fracture. That's called non-union, or delayed union where it just takes longer. And so there's lots of factors which can influence union, and that obviously to do with the health of that particular patient, their nutritional status, things like their bone density status can make a difference, or certain extent what they're doing whilst that fracture is actually healing. I also mentioned apophysitis conditions. So apophysitis conditions can include Osgood-Schlatter's and Sinding-Larsen-Johansson syndrome at the knee. There are other apophysitis conditions at other joints. And I mention these together because both Osgood-Schlatter's and SLJ have similar mechanisms of injury. Both are characterised by inflammation at the growth plate. So in Osgood-Schlatter's, it's at the tibial tuberosity, and in Sinding-Larsen-Johansson, it's at the inferior pole of the patella. So it's at the sort of epiphyseal growth plate, and it's thought that this sort of highly active children who are putting a lot of force through the tendons find that the tendons begin to pull on the epiphyseal growth plate and cause an irritation and inflammation of that growth plate. So it's more common in active children and often associated with a growth spurt in adolescence. The problems are characterised by very specific pain at that point and tenderness at the specific point. So if you squeeze the inferior pole of an adolescent with Sinding-Larsen-Johansson syndrome, they will tell you about very much specific pain at the inferior pole of the patella, or likewise on the tibial tuberosity. The conditions tend to be self-limiting, but they can take up to a couple of years to resolve. So this is a brief consideration of some of the overall conditions that you might come across in the knee. I've kind of collated ligamentous injuries all together, and I haven't really talked about bursitis in any great detail, but we'll come across that in the management of the knee. But it's worth making sure that you're aware of the sort of classification of ligamentous injuries, of fractures, and of some of those kind of growth-based conditions of the bones around the knee joint. Okay.